County HIV Planning Group requested that we present a webinar featuring researchers, community partners, and service providers of syringe services programs to help inform our local plans and funding for this important work in the context of HIV prevention. It is now my pleasure to introduce Dr. Britt Scathen, who is an assistant professor at the University of California, San Diego, in the Division of Infectious Diseases and Global Public Health. Her research advances infectious disease epidemiology through a combination of methodologies using social network analysis and epidemiology to produce evidence-based results that inform intervention and policy. She also coordinates the Division of Infectious Diseases, Global Public Health, HIV, and Substance Use Seminar Series at UCSD, along with her partner, Dr. Claire Bristow.
Welcome, everyone. Thank you so much for joining us today. We are thrilled and very fortunate to have a diverse panel of experts that are going to be fielding questions. And the way it's going to work is that there will be 5 different questions, and we'll have about 15 minutes for the panelists to discuss each question. And then following that, we will open it up to questions from the audience. So before we begin, I just want to give everyone a moment to introduce themselves. And let's please start with Bob Lewis. Oh, Bob, I think you're on mute.
Yep. You'd think I'd have the hang of these virtual meetings by now. So good morning, everybody. I'm Bob Lewis. I'm the Director of Special Populations for Family Health Centers of San Diego. Portion of the services within the agency that I oversee are our harm reduction services, which includes our syringe service program all the way through our outpatient residential treatment program.
Thank you. And next, how about Jacenna Garcia?
Hi, I'm Jacenna Garcia from the National Harm Reduction Coalition. I am the Capacity Building and Community Mobilization Manager for Southern California, and I'm based in Los Angeles. I have about 20 years of experience working with people who use drugs, folks that have mental health conditions, and people experiencing homelessness, and I'm happy to be here. Thank you for having me.
Thank you. Silvana Mazzella.
Hello, my name is Silvana Mazzella. I'm the Associate Executive Director at Prevention Point Philadelphia. I've been there 12 years. We have about 18 programs that have all eventually come out of the syringe service program that started in 1992. And among other things, I'm involved in the planning and evaluation of a lot of these services and implementation as well. And I hope that we have some good information to share about including a multidisciplinary model of syringe service along with other services that people need.
Excellent. And next is Tara Stamos-Biseg. Apologies.
That's okay. Hi, I'm Tara Stamos-Biseg. I am the Executive Director of the Harm Reduction Coalition of San Diego. Our syringe service program is on point, and we are a community-based organization led by people who currently and or formerly use and or inject substances, and also sex workers. We have currently been funded through CHERI. It's a grant through the California Harm Reduction Initiative. We have a mobile needs-based syringe service program. We're on the streets of San Diego providing fentanyl test strips, safe smoking and injecting supplies, naloxone, case management, referrals for Hep C, HIV, and we're getting ready to roll out COVID vaccinations on site. So we have started the program in October of this last year, and we've already enrolled more than 1,400 drug users in San Diego County. And so as a former person who accessed the program that Bob was speaking of, I developed this program out of the gaps in the systems and the things that I couldn't do as a substance use counselor or a case manager or a social worker, because I've worked in all those fields. And this is kind of the place that I landed to fill those gaps and do for the people that things that need to be done with love and compassion. And that's who I am.
Thank you. Pete Davidson.
Hi everyone, I'm Pete Davidson. I'm an associate professor in the Department of Medicine at UC San Diego. I've been doing research and intervention design around syringe distribution for about 25 years now, originally in Australia, that's where the funny accent's from, and since 2000 here in California.
Thank you. And last but not least, Steve Shoptaw.
Hi, I'm Steve Shoptaw. Thanks for having me here. I'm from Los Angeles here at UCLA. I'm a professor in the Department of Family Medicine. And for the last 30 years or so, I've been working on developing behavioral and medication treatments for people who use drugs, primarily people who inject opioids, as well as people who use stimulants. And I've got a whole line of work, and I'm very excited to be here to talk about the gaps, as Tara mentioned.
All right, thank you everyone for those great introductions. We're going to move to our first question. So the question is, what is the history of SSPs in San Diego? How have political issues emerged over time, if at all? And we're going to start with Bob Lewis for this one.
Okay, let's see. I could talk for days about this, but I'll try not to. And I'm making a disclaimer that what I'm sharing is just history of the legally sanctioned programs in San Diego. Over the years, there's been other programs that have operated. So let's see, in terms of just history, some key dates. I think, Liz mentioned, like back in the day, 1997, Board of Supervisors, passed a resolution banning syringe services. Then moving forward to January 2000, the state passed some legislation that decriminalized syringe exchange programs. However, they required a local declaration of emergency, and it had to happen every 2 weeks. So of course, in San Diego, our Board of Supervisors was not interested in doing that, but the San Diego City Council did take that on and did declare the state of emergency. And shortly after that, they pulled together a group that they called the Harm Reduction Task Force. And that group spent about 6 months looking at different models across the country, some in other places across the globe, and came up with a proposal in terms of what they thought would be the best plan to move forward with syringe services within the city of San Diego. So that was adopted by the city council. And then shortly after that, there was some funding made available through a private foundation to offer, to fund a pilot program. So Family Health Centers, my organization, started the project. And in February of 2002 is when we first started providing services. We have operated for the most part without interruptions since that time. And in March of 2018, we were actually able to expand our services. And then, getting closer to present date, just recently this year, Board of Supervisors, voted to, take a look at syringe services, which is very exciting. In terms of a little history, I'll also throw in there that, over the recent years with the syringe services, we've played a big role with the county and city public health departments in terms of addressing the hepatitis A outbreaks and the COVID outbreaks because of the people we're working with. So it's just kind of interesting that the county's had some interest in the people we serve when they need to. In terms of the program that we have implemented, it's in accordance with the plan that was approved by the city council. It involves a mobile unit that goes out into 2 neighborhoods in San Diego. With the individuals that we work with, we don't collect any identifying information. Each person's provided a unique identifier that's based upon information they choose to provide to us. And within our system, it's not linked with our EHR system at all. We offer comprehensive harm reduction services and safe injection supplies, in a respectful, non-judgmental way. In the recent years, we have been able to add naloxone distribution, hepatitis C testing, treatment, and now medication-assisted treatment to the services that we offer. And whenever possible, we're always trying to incorporate, peers into our service delivery. The model that we adhere to, there is a cap of 50 syringes that can be provided per visit. Much of that is limited by funding, but there is no limit on the number of times that someone can have a visit during a week to one of our units. We provide referrals and navigation with those referrals. We also are very focused on community engagement, both just the initial community engagement that we had to do to get things up and going, as well as the ongoing community engagement. We also put those types of efforts into our cooperative efforts with law enforcement. Because of the education that we have done with San Diego Police Department, since we first started the program, we have had buy-in of our program from the multiple police chiefs that have been in place. We do education with the officers that are on the streets to also help them, understand and hopefully embrace the program. One of the other requirements is there's a program facilitation committee that's put in place. So it's a group that has provided oversight to the program from the beginning. And actually most of the people on that group have been there since the beginning. The group includes representatives from the neighborhoods that we're serving, as well as the city council offices that represent those neighborhoods. It includes myself and our evaluator. There's always a seat available for funders that are helping to make the program work. And there's also a seat for staff from UCSD, San Diego State, and a treatment provider. So that's, we're really interested in making sure that there's, people who are staying on top of current changes and best practices so they can help inform and guide. And then other community members are also welcome. And there's also been a representative from San Diego Police Department there. So since our program started, we've served just over 15,000 unduplicated clients through about 250,000 visits. We have given out about 6.5 million syringes and taken in 7 million. And the reason that's larger is because we've also been able to provide safe syringe disposal services for the community. Let's see, we've given out 84,000 referrals, 74,000 harm reduction kits. And since we started offering naloxone on site, we've given out 5,000 kits, each with 2 doses. We have also, since mid-2019, we have administered naloxone to 24 of our clients who were overdosing on site, which is an interesting thing because up until that point, it had not happened at all. So let's see, in terms of who we're serving, most of the individuals we've served have been men, about 60%, the rest female. We also have a group of transgender individuals that use our service. About half the people we're serving are white, 32% Latino, and 11% Black. Interesting, most have never been married. Average age is 38. And 45% of the people we're serving have some college or an advanced degree. Many are unemployed, but there's still a group that are employed. And many are homeless, but also there's a large group that own or rent their place of residence. And I guess I just add that there because with the community engagement that we're doing, a lot of what we face is some preconceived notions about who an injector looks like. And it's clear that the people we're serving don't necessarily match that assumption. Over the years, we have made ongoing efforts to educate all the policymakers, law enforcement, and the communities we serve. I do like to think that we've played a hand in helping Board of Supervisors get to where they are. I think the community engagement piece is one of the things that has really helped us be successful in a conservative community. We've not only continued to operate, but we have been able to expand services. I think early on we learned that NIMBYism is alive and well, but that it was driven by a very vocal minority. And that once we started providing education and accurate information, that really helped people get a better understanding and be more supportive. It also created a possibility or an opportunity for community members to start sharing their own stories. People had concerns that we were going to be importing drug users into their neighborhood, but then they started hearing their neighbors saying, it's like, well, my neighbor, my brother, my spouse have all struggled with addiction issues, and all of a sudden it was something that was relevant to them. And I think that was helpful. Ongoing efforts to engage with law enforcement have been really helpful. They have continued to be supportive. The facilitation committee that I met has been very helpful. And I guess just our own ability to identify resources and leverage things, because over the 20 years, funding has not been consistent. So we've been able to leverage and at times just absorb some of the costs of the program. And I guess at this point, I'm just really looking forward to ongoing expansion of services in the county. There's a lot of unmet need, and I think expansion, hopefully our own program, Tara's program, other programs, there's a lot of need. So there can't be too much service, I believe.
Thanks, Bob. Would anyone else like to chime in on this discussion before we move to the next question? Okay, no problem.
I will say, I do
sure.
think it is important. What Bob is talking about is about keeping the pressure on the politics people is important. In Scott County, Indiana, they have reversed the syringe exchange access currently. And this was an HIV outbreak. In West Virginia, it's illegal to have syringe exchange in the entire state where they have an HIV outbreak. So, I don't want, I think it is important to remember that we need to stay political. Some of us do.
I want to add a little bit to that and say that, yes, we need to stay political, but we also need to remember, I'll add to that and say that showing up polite and with good data and meeting those politicians and the supervisors and the board of supervisors and the city council, meeting them where they're at and connecting with them in the same way that we do with our clients, showing up compassionate and finding out what they're willing to do rather than forcing them to do something that we're not, and kind of recognizing that we might have to roll with resistance with the same way that we do with program participants, with community members or with law enforcement or whoever. And so building those relationships with individuals while also remembering to include the voice of the individual who's being served and impacted the most, because we can do that a lot of top-down stuff, but if we don't keep those people at the table on the task force and uplift our participants, train them on how to use their voice, provide them with opportunities to sit on task forces, to attend education trainings. I think all of those things are key to facilitating some change.
Can I also add that it's really important to be good neighbors? We do something that many people still find extremely controversial and unpalatable, and it's really important to be mindful of that and you know, I think while we first and foremost absolutely start other services attached to syringe service programs to meet the needs of the people that come to those programs, we also do things to build support in the community and to build some goodwill, so that we expand a food resource or something else to the community.
We do have one question in the chat. I don't know if we have time for it or if we have to move on, but the question is, how is stigma dealt with access to the mobile units, if there is any stigma present?
I guess I'm not quite sure what that means. Would it be stigma experienced by those we're serving, or?
I
So
believe that's what the question is. Yeah.
Okay, so I guess our mobile units, we go out into the community on a regular basis, and many of the people that we're providing services to are very similar to those who access our syringe services. So I think there is, you know, staff are very comfortable working with the group and understand the needs and are able to, you know, provide services in a respectful way. I think the clients that are using our services, there's all a sense of trust with family health centers, you know, when they see us. And even just the fact that we've been, you know, providing syringe services for the last, it'll be almost 20 years. So I think trust has been established.
Thank you.
I'd like to add that having been a participant of that program and then working as a volunteer and then as a peer support specialist for the syringe service program, before I started my own, there are a lot of opportunities for individuals to show up with their trauma and all their stuff in a short period of time. And so even with the best training, stigma still happens. People have and I'll touch base on this in a little bit, but people have so much medical mistrust, and even with the great community relationships, if languaging is even like an addict, a junkie, words that are very stigmatizing, if those words are used versus a person struggling with substance use or a person engaging in chaotic use, or however it may be worded, and it's not about intention to harm, it's just not about knowing better. And I think that all of us are here today because we want to know better, and when we know better, we do better. And so I think there's a real movement to change a lot of languages. As a person who has lived experience and is in recovery myself, I've done a ton of my own work around how do I language so that I'm not creating more stigma. Do I have clean time? No, I am a person who no longer engages in chaotic use because I wasn't clean or dirty, and I don't need to recover from anything. I am even, like Lori's saying, I'm a person who no longer struggles with substances, or I'm a person who substances worked to as a coping mechanism or to address trauma. And when I take the behavior and the badness and the criminalization and the black and browning and all the things that are around substance use away from it, then I think folks feel a lot less stigmatized. And there is a ton, even with internal training at family health centers, because there's a lot of cultural competence training, but there can never be enough cultural competence training for working with people who inject and or use, because you have homelessness, complex trauma, you have stigma, judgment, fear, you just have all the things. And so you need ongoing training. Burnout happens and staff turnover happens. So a once a year training isn't even enough. And you need to, most importantly, hire and find from the community who has the experiences or people who are comfortable working in a place where trauma happens. It's a very high burnout. And I think all of those are important things to keep in mind. I hope that answered the question, Raul.
Yeah, this is a really good segue to our next question that asks just about some of these things. So the first part is what are some examples of successful models of SSP delivery? And the second part really speaks to what you were talking about, is how can we best integrate SSP delivery with other services such as access to food and housing? Sorry, and we can start with Jacenna and Silvana for this answer, please.
Yeah, so I just wanted to, I know we've talked about this a little bit, but I just wanted to start off by saying that syringe services are not just about syringe. They also provide a slew of other services, like Tara was mentioning and Bob earlier. You know, that is a connection and the link to a lot of other services that happens because we are building that trust and that engagement with folks. So I just wanted to bring that up quickly, and I know others are going to touch on that, so I won't get too much into that. Some of the successful models are storefront, street-based mobile outreach, like Bob was mentioning, or van and backpacks, secondary delivery with peers, and then pharmacy or physician. And obviously there's benefits and challenges with each of those. You know, I think for me, in my experience, I think the best models are going to probably be the street-based ones or the mobile ones, because they're really able to meet people where they're at. But you know, not everyone has the capacity to do that. And, you know, with secondary or peer delivery, that's also, you know, a great model, because you have folks that have lived experiences, that are a part of the community where that trust is already existent, and they're able to really reach as many folks as possible within their communities, their family, and then spread that knowledge elsewhere. And it's really empowering for folks that are doing this work to be able to then help others. I'm sorry, were you gonna say something? Oh, sorry, I thought I heard somebody. With the pharmacy or physician, it's something that can happen right now. So any physician or pharmacy can give needles to folks that are requesting that at any time that they need. You're able to come in and give somebody a prescription for needles, or even naloxone for that matter, as long as you're 18 and over. And I don't know if you want me to touch a little bit on also the second part of the question, and how to integrate services and access. We used to, similar to what Bob was saying, I used to run a mobile unit that was providing primary health care, and we partnered with syringe service programs, and we would go and do outreach in the community. We would go to the riverbeds, for instance, and we would we would give clean syringes, we would do wound care, and then bring folks to the mobile unit to get primary health care. We would be able to connect folks to mental health services, detox treatment centers, pretty much anything. And I really encourage HQFCs, medical providers to really partner with programs like Tara to be able to provide these services, and just really looking at whole person care and integrated services. As I mentioned earlier, SSPs are already doing a lot of this other work. You're providing food. I know that a lot of programs, especially during COVID, were being asked for food as opposed to needles, just because a lot of folks were no longer providing essential needs or other essential needs for folks like food. So food banks, and, you know, at clinics, like I mentioned, you have the capacity to really bring all these services to folks that are needing, people who use drugs, and, you know, not necessarily looking for detox, but any services.
So I have some similar responses and experiences. I think the most common models we see are the in-building model, the mobile model. We have syringe service programs that are the start of everything, the genesis of all of the other programs that then grow from them. And we've also both seen models and helped other programs and health departments that wanted to add syringe service program to, for example, an FQHC or another type of medical service. We have examples of hospitals that are at least in the contemplation or early implementation stage of, for example, potentially distributing safer injection materials to people who will not accept treatment, for example. We have examples of how syringes can be delivered to people. So the staffing model that can include staff that are specifically syringe service staff, harm reduction specialists, when materials are distributed exclusively by people who use drugs, and then the combination model. And most definitely, I think this has been talked about a lot, but I think the absolute best practice is that we are serving people who use drugs, but we are providing services through people who use drugs or have used drugs. And to the extent that we are true to the people we serve and what we provide is what people are asking for, we have the most successful models. In terms of the, I'll talk just a little bit about the in-building versus mobile, because it also relates to the question earlier about stigma. So for example, we have mobile sites most of the week, and then we have in-building syringe service program 4 days a week. And so a total of 6 days of services. And what we saw, for example, in the in-building program, when that started, because that was not an original feature of our syringe service program, when we began to provide services in the building, we saw a huge influx of people come into the building from the street for that initial site. And as we've added sites in the building, we also see those grow exponentially. In some cases, we've seen the mobile sites closest to the in-building site decrease fairly drastically for people to then start coming to get services in the building. In other sites, we see even a growth at those mobile sites. And so I personally think that offering that kind of hybrid model really allows us to serve everyone. There are people that do feel stigmatized in some neighborhoods on the street. We've had situations, and I know this happens in many places where, for example, law enforcement may have come to a mobile site. We have had instances where people in the community are unhappy with the start of a mobile site or as it gets larger. And simply put too, on a small vehicle where you might even have private rooms or tents outside to provide private, semi-private services, many people will not want to share their medical concerns or apply for public benefits or do anything else or have a wound looked at or dressed out there, especially if they've had to wait on any line, no matter how short it is. And so the opportunity to provide a service in the building where you can layer multiple services, I think has been really helpful. And we've seen the uptick in the instances where we've done that. And the other thing is that while many people in the community know why people are coming to the building, you can also be coming to apply for benefits. You can be coming to ask for help with substance use treatment. You can be getting substance use treatment with us. You can be getting food. You can be getting coffee. You can be getting your mail there. You might live in the building or one of the other respites that we run. We're not currently housing people in our main building, but we have in the past. So the ability to provide a service in different ways is critical as a best practice. But similarly, as was said earlier, what we also see with our mobile sites, and this is not just for syringe service program, but for mobile medication assisted treatment or for mobile wound care, or for mobile testing and linkage to care for HIV and hepatitis C. We see that there are people that will never come into a building, not even ours, no matter how much credibility we have in the community, no matter who is doing outreach for the service. And so we may end up seeing fewer people sometimes at certain types of mobile sites. Again, an example is wound care, where we might see 4 or 5 times as many people at a wound care site in the building, but out on the street, we are seeing people that don't go anywhere to get their wounds treated and seen. So those are kind of critical differences. I think the other just thing to highlight when we're talking about the additional services to be provided is, as has been said, ask people what they need. Don't assume what people need. Don't assume that they need this type of healthcare or this type of food or this type of substance use treatment or this type of clothing. It doesn't matter what it is. Ask people always, what else do you need that we could be providing or that we could get someone else to provide? And that kind of leads everything. So we know that people are hungry, and when they are treated by the medical providers, we find that they are malnourished. We know that people are unsheltered and need housing. Sometimes they don't want the housing that we or other people are offering. They may not want long-term housing or permanent housing or a subsidy or somewhere where they have to show up every night, but asking those questions, and then that is what we try to provide. Asking about the type of clothing and other survival resources people need. Things like showers and public restrooms. Public restrooms are something we added a few years ago, largely because of the hepatitis A outbreak, and we were able to do that, though we had been doing it in our building, but the ability to do that outside and provide a very low barrier way for people to address their hygiene needs. Medication assisted treatment. And just because we have it on site, many people do not want to get it from us. So we have the opportunity to provide other resources, but consistently asking people what they need. Do you need a place to just hang out for a few hours? Do you need a place to sleep? What do you need in terms of other resources or healthcare or legal resources, including a lawyer to resolve potentially or look up things like bench warrants and court dates. And so layering that is critical as a best practice. And including also in that additional service delivery, a look to how we can also be good neighbors, because many people do not like what we do. Many people do not like the people that we work with. And so any other types of resources that both serve the people that we are serving, but also that can potentially help the community make a big difference. And an example that's already been alluded to, it could be meals and water and other types of survival resources, clothing, but also COVID vaccines, COVID testing, public meal sites, things like that, that are palatable to the community at large, are critical.
That's a great point. I just wanted to add, speaking about, needs and language earlier from Tara is, yes, definitely asking folks what their needs are, and having them self-identify what their usage is, not putting labels on folks and stigmatizing with that. And then one key thing that I did forget was, although it's not as easy to practice, is needs-based services, right? And so we moved away from the term needle exchange because this should not be a one-for-one. I know that there's limitations on funding, but we really want to make sure that people's needs are being met and asking what their needs are, and distributing syringes based off of that need. And I just wanted to quickly add that because I know we have other questions to get to, so thank you.
Thank you both for those thorough answers. We do unfortunately have to get to the next question. So we have touched on this question a bit, but What barriers have the community of people who inject drugs faced in getting the services that they need? And what barriers have service providers faced in maintaining their operations? And we're going to start with Tara for this one.
Okay, I think it's a long list, so bear with me. The first barrier I think that we've identified and we've talked about a little bit is stigma. The discussion needs to be had around the stigma that's encountered by people when they have their first medical encounter with the person who answers the phone and the person who is in the front office and the person who is walking them back to the room and taking blood pressure. Because if the provider is confident in working with people who use and or inject, but the front 3/4 of the encounters are not, they're not going to come back. And so I really think, but our folks, people who are homeless aren't necessarily doing something illegal. People who are living with HIV are not necessarily doing something illegal. People who are doing lots of things aren't necessarily doing something illegal, but a majority of our participants are using drugs that are criminalized. And so the built-in internal shame and stigma from that is a starting point. And then when society and services kind of validate that, it's a big barrier for a lot of people to treatment or to accessing any sort of services. And I think another one is going to be legal status. We have people who are on parole or probation. They have warrants. They have, especially here in San Diego, we have individuals who have immigration issues, and that's a barrier for a lot of people. We have folks that we're meeting right now down in the riverbed near the border because they're afraid to exit to access services because they don't want to be grabbed up by the immigration service. So that's one. I would say trauma and the ongoing life of a person who is using drugs, the trauma that we experience when we access services, the trauma that of living on the streets, the criminal justice system, just there's so many layers of trauma. And I think that's a big barrier for people who are accessing services, because if I'm struggling with trauma and I show up to a service and I'm dysregulated and I'm angry and I'm snappy because somebody on the bus just said something to me and I worked really hard to get here, I have a limited time, I worked hard to get here, and somebody on the bus said something that triggered my trauma, or maybe my day's been traumatizing, I don't know. And I show up frazzled, or I show up just like a person who in trauma shows up, and I'm labeled a difficult participant or a problematic client, or rather than a person who is struggling with problems or somebody who's navigating trauma, or and I think that's a barrier. I don't think I've heard from people that that's a barrier, and I think this last year has really shown us that isolation is a tremendous barrier for our folks. It always has been, but I think our lens has changed a little bit so that we're able to see even more. And then this year has provided a space where that stigma has driven drug users even farther into isolation and away from other services. And so I think isolation is a big barrier. We have people who live on the reservations. We have people up in Boulevard, which is way in East County. We have people in Ramona. We have people in the riverbeds. We have, we have people who are isolated and far away from any services, any transportation. They may not even have good Wi-Fi or any Wi-Fi. They may not have any Wi-Fi. There are people who have purchased trailers with the EDD money this last year, and they're doing great because they are surviving in a community of folks up in the hills. But there's a bunch of folks who don't have Wi-Fi access. They're a community of people who are looking out for each other, and they don't have access to any of these services. Although they have a place to live that's sheltered, they have shelter, they don't have services. And so that's a barrier. I'd say transportation's a huge barrier. People don't usually have bus passes, and even if they do, can they bring their belongings? Is their pet allowed on the bus? Is there hygiene okay to show up? How are they presentable enough? Again, that stigma. Am I going to show up on the bus? Like, am I cool with how I'm looking? Am I going to feel good about that? That's a big barrier for people. I think looking at people's different ability to access services. Do they have cognitive issues? Is there intellectual stuff going on? Is there physical different abilities? Does somebody use a walker or a cane or crutches or have a rechargeable scooter? Do they have a hard time seeing? Are they missing dentures? Do they have hearing abilities that they're struggling with? All of those things are things that our folks struggle with even accessing syringe service programs, and we're often the only access point for anything. So if they're not accessing us, I promise they're not going into the welfare office, they're not going to the doctor's office, they're not going anywhere. And so those are barriers. I would say the drug use itself is a barrier. We have individuals who are afraid of leaving their drug supply or their drug paraphernalia stashed in a building or stashed in bushes to travel, because they can be arrested with those things, and people have adapted and figured out ways. But I would say that, and then all the things that come along with drug use, the difficulty struggle and living on the streets, the difficulty struggling with time management, and do we even know what day it is? Do I know what time it is? I don't have a watch. I don't have a phone. If I have a phone, I don't have a place to charge it. And so I can't keep my appointment. And so those are all barriers that we have heard folks sharing about. This last year, people have really shared that masks have hindered their ability to read body language, to see, like, we survive on the streets. You and I are looking at each other today on this with our facial expressions visible. But if we were all masked, I wouldn't know if Peter was angry or if Bob was laughing. Like, I wouldn't know. And so my normal coping skills of being able to protect myself on the streets while I'm looking around and everybody's masked, that's really heightened a lot of people's ability to do things. Conspiracy theories have been a huge thing in this last year. Political stuff, stuff around public health and COVID. We're doing some research around what that all looks like actually right now. And so people are afraid to wear masks, and people are saying, I have the right and I'm not wearing it, but then service provisions require that. And so how do we work with people? We've gone and bought the clear face masks so that we have clients who won't or can't or don't want to, and we hand those out, and we work with people to find ways to do stuff. And I think another ability that we have, another barrier that we have, is the lack of person-centered services here in San Diego. They may say they're person-centered, but it's not based on an individual's right to self-determination necessarily. There's an end goal of abstinence maybe, or there's requirements. I know that Family Health Centers is in an operation and sustained for a long time, and because of funding and the policies from the early 2000s, and but the one-for-one stuff is a barrier for 95% of our participants. I see people on a daily basis who because of all those things I previously mentioned, have lost or thrown away or stashed or had confiscated or traded or shared or thrown away their stuff. Because if I'm carrying around a bundle of needles that I need to take to trade in and I get pulled over, it doesn't matter if it's 3 days before the exchange, I'm going to get, even though the laws are changing now, but information about change laws doesn't hit the streets till years down the line. And so I think those are barriers for people. Education is a barrier for individuals accessing services. Do they know about fentanyl? Do they know about proper safe injection? Where did they learn how to inject? Who has taught them about drug use? Who has taught them how to safely inject? It's usually community driven. So you're learning from the person you used with or the people that you're sharing supplies with. And that can be a barrier for people. I think the lack of follow-up from other service providers for the participants that I see. One of the number one things people say is, I don't get calls, but they asked me, but I haven't heard anything back. Nobody has followed up with me. I need to get tested. I haven't got a number for Suboxone. I don't know where to go to get it's the lack of wraparound services for people who are still using substances, because there's a real goal for most programs to kind of exit somebody from that life. And my goal is, if that's the person's goal, is to help them in every way possible to exit. But if it is not their goal, how do I help to provide a place where they feel safe and heard and supported and able to make decisions that may eventually lead to something greater. And in the meantime, though, is really supporting an individual's right to decide. And I think access to prenatal care is a huge thing for our participants. I have a lot of women. I myself am a mother who, while I was living on the streets, became pregnant doing sex work, and I was not able to access prenatal services. And today I have I live with those things, and it's not just me that struggles with that. My own kids struggle with that. And but I did the best I could. I didn't have somebody out there who said, if you aren't going to access medical services, here's what you can do. Or I know a place where you don't have to share that your name or that you are CPS involved or any of those things. There are so many barriers. I mean, like I said, and we talked about prior to this, we could go on forever and ever about the barriers for individuals. And the great news is that now San Diego is in a position to finally talk about, how do we address the fentanyl issues that we have here in San Diego. We have a huge a fentanyl. It's not going anywhere. We tested 15 supplies last week in Point Loma, and every single one of them were positive for fentanyl. Pressed pills, meth, heroin, and what was being sold as fentanyl. All of them. And everybody continued to use. Nobody did not use because it had fentanyl in it. And I'm sure people from the county are on this call, and I'm going to say this with all the love. But the fentanyl billboards, they're great, except for they just say fentanyl kills, and there's a penny with a little piece of fentanyl on it. But I talk to my participants who live in PB and La Jolla, and they're like, but what do I do if it has fentanyl in it? Where do I go? How do I get Narcan? What do I do if I still want to use? And so educating people around those things is super crucial right now. And I'm going to say, if we're going to even tackle this, that the conversation for our participants needs to be had about finding and supporting providers who are not only interested in, but competent in microdosing and helping individuals to get from fentanyl use to not struggling, because there are very few detox beds in the county, and those detox beds have a very poor system in place for people who are detoxing from fentanyl. The people who leave the program, I don't know what the numbers say or what the facts say, but the people who walk away from those programs are saying, I couldn't do it on 2 days of Librium and then Suboxone. I couldn't make it. I had to leave. And so those people are left to go back on the streets. We cannot address those things if we don't look at the barriers that people have of, discussing poison drug supply and all of that. So I'm sure I have a lot more barriers, but we do provide, I saw a question on here a minute ago. We do provide fentanyl test strips. We just ordered 2,000 of them. We give them out 5, 10 at a time. We encourage people to test their supply. We are working with be careful about how I word this. We're working with individuals who may supply drugs in the community, and we're providing them with fentanyl test strips and education about what it looks like if you are knowing that you have fentanyl in your supply and now you're getting it out. There's some repercussions behind this, and if you if you are going to use this supply, it's your now responsibility to share with the people who, because we talk to folks about testing, and what we're saying now is assume that it's positive, assume that everything has it. Don't even worry about tests. I mean, you need to test, but assume that it is. We hand out 2, 4, 6, 8, 10, 12 boxes of Narcan at a time and get it out to people. But access to naloxone is a huge barrier for people. So,
Thank
and then
you. Sorry, apologies.
I wanted to
Sarah.
say
Go ahead.
real quick about the service providers, because I know I didn't touch on that, but I want to say, I think the inability for service providers here in San Diego to even do real harm reduction has tied the hands of people in family health centers or in UCSD or in other organizations who wanted to do the work. The county couldn't support it. The county wasn't able. And so I think everybody's kind of done what they could with the best of what they had, but we know better today, and we're here to do better. So I think the importance of evidence-based best practices when it comes to providers, and the support for the providers to implement those. Enough workforce out there. There's not a lot of training for harm reduction. I know in all of the, I am a certified substance use counselor and a case manager, and I am working on knocking out, becoming a social worker in school for that. And in all of that, I've had maybe 45 minutes of training around substance use and a few pictures of, here's an abscess, and this is what it looks like when you're on drugs, and kind of a thing. And it's very, it's not informative. And so, we have a number of medical students, I think some are on the call today, that are building harm reduction into what the work they're doing. But I think working with homeless service providers, there's a human services class that at City College, that's a homeless services brand new class, certificate program, but they're talking about harm reduction in there. And I think building those things in are crucial for service providers, and funding, and it is a huge thing. And I think the main thing I would say is the lack of bringing people with lived experience to the table, the lack of hiring drug users, the lack of including drug users in budgeting, and how to provide services, to what everything down to like what syringes are the best ones, what do you need, I think those are all things that service providers need to keep in mind, and remembering that at the end of the day, we can't change and save everybody's lives, but we can make a difference in a few lives and remind people that they matter while they are here, because we can't save everyone's life, but we can remind them that they matter for that little few minutes that we have an interaction with them. And not just as providers, but as people, I think we owe it to not just our participants, but humanity.
Thank you, Tara. You bring up so many important points that I feel like we could spend a full session on each one of them. So I apologize that we have to move on. I hope that some of this can come back in the Q&A session. I'm going, for the sake of time, to just move to the next question. And this is a question that I feel like we don't really talk about very often. And it is, what is the impact of data collection on clients, and what data are truly necessary for maintaining funding? And I'm going to give this question to Pete Davidson.
Hi, everyone. Thanks for having me. This is going to sound really odd coming from a researcher, because usually I love data, but since we're talking about best practices, I'm just going to sort of say up front that I think the best practice as far as needle distribution is concerned is to collect as little data as humanly possible. There's a really good reason for that. Well, there's a lot of good reasons for that. And I think we've ended up in kind of an odd situation with syringe distribution. When needle exchange first started in this country back in the 90s, it was and remains to some degree a hugely controversial form of public health. And when we started in the 90s, people had a lot of really good and reasonable questions about it. Is this going to actually solve, reduce HIV transmission? Is this going to have negative effects like increasing the number of people who use drugs or increasing the number of needles discarded in the community? And they were all good and legitimate questions. So we've done a huge amount of research over the last 30 years. And needle exchange has always had these very close relationships with researchers to sort of answer this kind of questions. And across the last 30 years, we have answered all these questions. We do know that needle exchange reduces the transmission of HIV and hepatitis C in communities. We know that in communities with needle exchange, people who use drugs who have access to needle exchange enter drug treatment more quickly than those who don't, and have shorter drug using careers than those who don't. We know that the number of street discarded needles actually decreases in communities with needle exchange. You heard Bob say earlier that they've actually taken in more needles across their operating time than they've given out. We know that law enforcement officers are less likely to get needle stick injuries in communities that have exchanges than the ones that don't. We know that needle exchange is the most effective way of getting naloxone into the hands of people who use drugs. And in communities where that happens, we see statistically significant drops in the number of overdose deaths. So we've sort of, over the last 30 years, we've answered all the questions that we had about, does this stuff work? But we've sort of been left with what, to me as a researcher, has been this really embarrassing legacy where it's really normative to ask people distributing needles to collect rather ridiculous amounts of information about what it is that they're doing. I can't think of another public health intervention where we so routinely collect so much information, both about what we're doing and about the people who we're providing services to. As a researcher, I'm very much aware that anytime you collect data, that comes with some sort of risk or burden associated with it. And in fact, when I design a new research study, I have to go before an ethics board and sort of say, here are all the possible ways that collecting this data can hurt the people or the community that I'm doing research with. And here are the benefits I'm hoping to get from this. And I've actually got to make the argument that the benefits make it worth taking that risk. We know that collecting data at needle exchange actually has some risks associated with it. I did a study a couple of years ago surveying needle exchanges all across the country about how does data collection affect your ability to deliver service? And people said really routinely, it scares off some of the people that we want to serve. Like people are concerned that we're going to give this data to the cops or stuff like that. And it doesn't matter that it's not true. It stops people coming in and getting these services that they need. And it's an enormous burden to service providers. You've got to spend hours and hours and hours asking all these questions and managing all this data and handing it off to funders and formatting it and all that sort of stuff. And this adds up to thousands and thousands of hours a year of labor that you could be spending actually delivering the service that people genuinely need. I'm not saying that every last bit of data collection is evil or bad or problematic. We do have ongoing questions. How is the drug market changing? Are there new drugs entering the local scene? But I think we can get really creative about how we answer those questions. We don't necessarily need to ask every single person who comes in to get a needle 20 questions. We can ask questions just for 2 weeks every 3 months, or to get a kind of snapshot of how things are changing over time. One of the big reasons people still collect data is because funders require it or local government require it. And, there is a reasonable case to be made that you should be answerable to how you're spending their money. But again, there's creative ways to answer these that don't get in the way of actually delivering service. Here in Los Angeles, we've had a lot of success talking to funders and talking to local government and actually pointing out how data collection hurts service delivery. And most of the time, funders and government have been like, oh, we never thought of that. Okay, here's what we're really trying to work out. Let's work out a creative way to actually get the answer to our question that doesn't screw up service delivery in such a harmful way. So I think it's sort of ethically imperative for us to sort of have these conversations with funders and other entities who's requiring data of us to sort of work out what do we really need to know and how can we find that out without burdening participants and burdening the service. I'll just end with a kind of analogy. There's another type of HIV intervention that we've had since the 80s, and that's giving out condoms to people. You imagine if in San Diego County, there were only 2 services providing condoms. And if you wanted to get a condom, you had to go and answer a bunch of questions about your sex life in order to get a condom. We know what would happen. We know that a hell of a lot less people in San Diego would use condoms. And that's exactly the situation we're currently facing with needle exchange. I think it is an absolute ethical imperative to work out creative ways to collect data only when we genuinely have a use for that data, and to not do it the rest of the time. And I'll stop there. Thank you.
Thank you, Pete. Because we're just running a little bit behind and I want the audience to get a chance to have their questions fielded as well, I'm going to move on to our final question, and that is, what has shifted since the COVID-19 pandemic, and how can we best assist the community in navigating an incomplete response by the systems in place? And we're going to have Steve Shoptaw answer this one for us.
Well, thanks for having me. It's really great to be here today. I think that a number of things that have been talked about are important, and especially the issue of COVID-19, as people have mentioned. You know, there are several common elements we're dealing here with, and that's poverty. For people who inject drugs, there's the setting of poverty that is really a big barrier. We have substance use and mental health disorders that are ongoing. We also have the unavailability of health resources. So that happened because of COVID-19. There are these telehealth things, but in terms of, like, as Pete was talking about, you know, getting access to free syringes or to condoms when harm reduction has been hit probably the hardest of all of the services that are necessary to preserve health for people who inject drugs. It's a problem. And if these 3 elements were oxygen, heat, and fuel, then we would have a fire. And that's exactly what we have right now. Is we have these fires, these hot spots around the country that have to do with infectious disease, that have to do with outbreaks of opioid use disorder, injection, and other sorts of problems. And with COVID-19 itself, it makes all of this even worse. So the idea of having bricks and mortar type services is great, as Tara was saying, but you know, if you can't get there, there's no need to have the service. The idea of having mobile services is really important and needs to be a part. And as Pete says, maybe there should be data on this. There is none really. I mean, if you look at the evaluation of mobile health clinics, there's been around a long time. It generally shows that it's helpful, but there's no real data to guide public health professionals. And then, you know, so we have these outbreaks now of HIV in the country. For the first time ever, we see the prevalence of HIV in people who inject drugs no longer dropping year over year over year. And in fact, it's bouncing around and maybe starting to bounce up. We don't know what's going on. You know, a lot of HIV testing has been sidelined. We're going to find out once we bring these services back online, and my hunch is we'll see more outbreaks of HIV, like in Scott County, Indiana, where now injection, we have the removal of syringe exchange. We have, Cabell County in West Virginia, where we have the removal of syringe exchange. These are going to be even greater problems than they are now. We have people in Rust Belt cities who are hopeless and don't have any sort of reason to engage health in the social network, like Lawrence and Lowell, Massachusetts. And, you know, in King County, we have the crossover of risk groups where women who inject drugs may share needles with men who have sex with men who inject methamphetamine, showing a hot spot that happens when risk groups can intersect. So there's a lot of issues here. And one of the problems that we have as we think, we need to challenge our thinking, is that we need to stop seeing that the problem is this and the solution is that. So that sort of thinking has led to this siloed care system, from harm reduction, from syringe exchange, all the way through, through formal substance abuse treatment. So no matter where you stop along the continuum, if you need say, mental health treatment, or if you're using methamphetamine as well as opioids, if you need housing or food security, if you have hepatitis and you need treatment or wound care, there are precious few places where somebody can get that kind of comprehensive integrated services, that one-stop shop. So this is really makes me crazy. It makes me, I get really passionate about this because, I can't keep up with this. So we actually launched this week, we launched HPTN 094, which is Integra, which is a test of what happens when we provide these integrated services in the same spot. So we're doing it in two ways. One is we're saying we're going to build a peer navigation system that will engage clients' needs. All of the things, all will help them get them to medication for opioid use disorder, provide naloxone kits, exchange syringes, be able to do wound care, to provide primary care, test for HCV, and get these guys onto treatment if they're willing. Mental health counseling, brief models, but links to serious mental illness care. These are the things we're doing as a activated peer navigation, but we're going to test whether you can get an incremental increase in terms of keeping people engaged in treatments and interventions if we provide those care within a mobile unit setting. So we're doing this in 5 cities, here in Los Angeles, in Houston, Washington, DC, New York, the Bronx, and in Philly, in the Kensington neighborhood. So we're actually going to collect some data that's going to help some of our peer, not our peers, but our public health officials to come back to our communities and say, we're not constructed to be able to provide competent care to people who need this care. And by the way, I don't think that people who use drugs are the only people who need integrated care strategies. I'm one of those folks who really benefits from being able to take care of 2 things at one time. So, I think it's a really strong idea, and it's something it's something that we need to do. So, I think I'll stop there. I want us to get some time for people to talk. And I must say, I'm totally energized by this discussion. I look forward to hearing what the questions are coming up.
Thank you, Steve. So we'll turn it over to the questions now from the audience. And I also just wanted to mention that I believe we have Patrick Luce in the audience from the County of San Diego Health and Human Services Agency. So he might be able to provide us some updates on local plans and also help us to field some of these questions. So we have quite a few questions. So our first one is, how do substance drug users and CBOs get invited to the task force? I think this came early on, so it was with regard to one of the first speakers.
So if this is regarding the task force that I mentioned, that task force was very short term, and it did its thing 20 years ago. In terms of the facilitation committee that I mentioned, that's open to anybody. And I'm just trying to think what is the best way to get information out regarding our next meeting. I can definitely send that, and if you can distribute it to those who attended the webinar.
Absolutely, we'll do that.
Okay, our next question is from Jaime. He says, we have many clients who are American citizens. Is there a way to promote binational NEP services, including targeted information for regular border crossers?
I'll answer that real quick. We go down to the San Ysidro border crossing and we do a lot of secondary exchange. We send a lot of stuff down there. And then we also are doing La Frontera. It's a study with UCSD, and it's looking at cross-border drug tourism. And so we're doing a lot with them. We partner at sites with them now here, but then I send stuff across the border. But I was working with Ronnie Grigg. He's from Vancouver and Jaime. I don't remember if you were working with him or not, but looking at doing some international work here in San Diego. It's time to do it. We have so many people, a good percentage of people who work for family health centers live south of the border. A good percentage of people that I know live south of the border because it's affordable. And I think it's important that we find ways to kind of make that work. So, but we send stuff down there and we meet people at the border on this side. Best answer I have for now, Jaime.
Thanks. I think we answered the question about fentanyl testing strips. If not, please remind us in the Q&A.
Can I add one thing? One thing that
Oh,
we're
sure.
actually looking to do is using a portable mass spectrometer. And that's something to think about bringing into the San Diego area. One of the things about the advantage of the portable spectrometer, whatever, the machine, is that it actually can tell you what's in the drug without actually using any of the sample, whether you use water or whatever, and you reuse the drug. A lot of people have misgivings about, you know, the sample, their sample being used in the analysis, and they like to have the mass spectrometry reading to just say this is fentanyl or this is whatever it is. And
Thank you. Our next question is from Ayas. Just a quick addition regarding access to syringes through community pharmacies. The law allows for a pharmacist to furnish clean needles to a person provided that the pharmacist establishes a legitimate medical need for the patient had previously been given a prescription for needles. However, there's an exemption to this rule that will expire in 2026. So moving forward, the law needs to be changed to allow pharmacies to continue furnishing syringes without a prescription. I think just a comment. Thank you for that. Let's see here. Another question from Jaime. Following on the topic raised by Tara, we have several people that come from SD to Tijuana and are getting OD from tainted supply. Is there a strategy to promote carrying Narcan if you are crossing the border to use?
There currently is not. I myself have had trouble bringing Narcan across the border. When I've walked across, they want to know what it is. They don't want you to have it in it. I think it might be easier to carry the injectable, but I know that it also then you have to have a different size syringe, or you don't have to, but you should. And I don't have a good strategy, and I think that's something that having a cross-border partners, we use people right now with Sentry passes to zip it across the border and then meet on the other side. That's kind of the strategy that we have right now. So fly under the radar.
I've walked injectable naloxone across the border, but yeah, I've had trouble with, you know, what is this? And, you know, I've gotten lucky because they've literally looked it up on Wikipedia and decided it's not a controlled substance, but I've been lectured about not having a prescription for it and stuff like that. So it's a little bit tenuous. And I could see why folks going down to use wouldn't want to carry it on them, because it would identify them as up to something.
Okay, it looks like this is our final question in the chat. In order to use needle exchange in San Diego, will you ask for ID?
So as far as family health centers, no, we don't ask for ID, and we don't ask people to share any information that could be identifying.
We gather very, very little data. And what we do gather is all voluntary, and we trust that our participants are going to tell us the truth, at least the same truth that they're going to tell us the next time. So that's what I tell them. If you don't have to tell me your name, but whatever name you do use, whatever initials, I just need you to use the same ones They can stand for something else, but I just need you to do the same ones next time so that we track for data. And if I explain it to people like that, because people are so skeptical about giving any information, but I don't know what the county's plan will be, but I'm really hoping it'll be super low barrier. So.
Thank you. We have a few minutes remaining, so I just wanted to give Patrick a moment to share local updates if he's on.
Good afternoon, everybody. Thank you so much. Just make sure you can hear me. The call of 2021, making sure that people can actually hear you on these calls. Thanks so much for this really great presentation. I've taken an enormous amount of notes. I really appreciated Tara, the extensive discussion of barriers and Dr. Davidson, thank you so much for the discussion of really minimizing data collection. And we have not yet finalized the policies and procedures that will be used for needle exchange, for citing, implementing, or evaluating. But clearly we understand these very significant barriers, and no, we would not, I can't imagine that we would at any point decide that clients would have to provide ID in order to obtain needles. In the strategy that we've created, the harm reduction strategy, one of the most important principles is the involvement of people with lived experience in the principle of nothing for us without us. And how do we ensure that the communities of people who are using drugs or who have used drugs in the past really shape how we think about our policies and really influence everything that we do. We want to make programs that are going to work for people. Since the board passed this, since the board removed the resolution in opposition to needle exchange back in January, the departments of behavioral health services and public health services have come together for some really intensive planning about how are we going to do this. In the beginning, most of our planning has been focused on naloxone distribution and what we can do to curb the really astonishing increase in overdoses and overdose deaths here in the county. And we have stood up a naloxone distribution program. And so that's where our energy was focused in the beginning, but now we're really focused on how we're going to do needle exchange. And I want to be clear, we have not decided whether we will be doing this ourselves or whether we will be funding providers out in the community to do this, or both. It's my guess that we're going to be doing both. But that's going to be determined over the next several months. Our next step is something called a community readiness assessment. So we will be seeking consultants to come in and really help us determine where are we going to be citing needle exchanges, whether we do that via street-based mobile outreach or storefronts. Where are we going to cite them? How do we do the public opinion research in those neighborhoods so we can understand what the concerns of our residents are and respond to those? And what should our policies and procedures look like as we go forward? So that should be coming out, that procurement should be coming out in the next several weeks. And our goal is to have a contract in place by August. I also want to mention that through our HIV prevention funding, we will be issuing a procurement for comprehensive HIV prevention services for persons who inject drugs. And because we no longer have the restriction on involvement with clean syringe exchange, we are very hopeful that our successful bidders will include how we think about syringe exchange and getting clean syringes to our clients, to our residents. So that's sort of a really brief overview, and I'm happy to answer any additional questions if anybody has them.
I have a question. Go ahead,
I
Tara.
was just going to say real quick, Peter, thank you for all of the tireless work. I know that we've all been sitting side by side at tables for years now, way before the discussion of the harm reduction stuff came up. And thank you, Patrick, for being a champion and making sure that the voices are heard and that it is centered around people who have lived experience. I appreciate that. And bravo, because I know that's not an easy position to carry around. So thank you.
Jasana, did you have a question?
I mean, just to kind of uplift what Tara said as well, I'm glad that you're looking at meaningful inclusion of people who use drugs, Peter. And I'm wondering, you mentioned that you're interested in possibly doing a combination of providing, or collaborating with organizations like Tara, right, to contract to do this work. I'm just wondering, oftentimes for folks trying to get contracts with county, that is kind of a complicated process. And how are you looking at programs again like Tara that are able to really do that work, and contracting them to be able to help you expand services or provide services in general?
Thanks you for asking that question, and it's a great question, and something that I have heard. I work in HIV, STD, and hepatitis, and we've heard that over and over again, that a lot of smaller organizations or grassroots organizations are really challenged to compete for contracts because of one, the ability to be available and spend 160 hours writing a comprehensive proposal, along with the financial requirements to meet like insurance standards and stuff like that. And I don't have great answers to this yet, but I know that our Department of Purchasing and Contracting has been directed by our Board of Supervisors to think specifically about that, and how do we ensure that we create more abilities for smaller community-based organizations and grassroots organizations to receive funding from the county and contracts for the county. So I wish I had a more comprehensive and detailed answer for you, but I know that it's something that we are definitely looking at and working on.
Peter, Patrick, can I suggest some basic training? So maybe we just applied for this HRSA grant, and prior to the grant application, there was a little like open webinar, some basic information about the funding and what was being requested, and then an open line of communication was open so that there are questions along the way. And really, from the Cherry grant, it's 37 of us or 35 of us throughout California who none of us have done this before. And it's a series of learning opportunities that we're having to, maybe we didn't do it before, but I'm telling you right now that some of us are becoming extremely successful in the work that we're doing with just a little bit of funding, and with support to write grants, to find funders, to on that sort of support, some sort of a training. I think that would be a really great, and thinking outside the box in where you advertise for maybe the training, even if the funding or the grant stuff is in a different location, where you advertise is more broad.
Thank you for saying that. And I know that our Department of Purchasing and Contracting has done some of that. And certainly I think we need to do much more of it. So I wrote that down too. So thank you.
Well, we are currently at time, and I just want to be respectful of everyone's schedule. So we're going to have to end it here, but I just want to send, a huge thank you to our panelists. Thank you so much for sharing your insights with us today. And thank you for everyone who joined as well. I believe that you can get the recording if you would like it from Liz Johnson. So enjoy the rest of your day, and thanks for your hard work on this issue.